Patients with pulmonary arterial hypertension often need close follow-up to evaluate the treatment. If the disease state is relatively mild or on the moderate end at diagnosis, often they're started on oral therapies. More severe disease with functional class 4 heart failure as an example, or hospitalization for the pulmonary arterial hypertension at the time of diagnosis, often the therapy will start with infusion prostanoids such as treprostinil or epoprostenol. If we're dealing with the former group of patients, more mild disease that start on oral therapies as an example, when they're seen in follow-up as an outpatient, obviously their symptom burden is evaluated, their physical examination. Surrogate markers such as a blood test for brain natriuretic peptide or a 6-minute walk distance are often performed to evaluate whether or not they're headed in the correct direction. Are all of these things moving toward an improvement? If so, then generally the therapy is unchanged and continued. If, however, the patient is not making progress or is deteriorating, then the therapy is accelerated. The current state of the art is using sequential medications as you would evaluate the patient, with one exception. There is a more modern study that shows that at least 2 of the medications that are now approved for pulmonary arterial hypertension might best be used very early in the course of the treatment. A trial that's called Ambition, where tadalafil is used together with ambrisentan. But short of that one trial, often patients are started on one therapy, evaluated in a very short time frame. If not doing as well as anticipated, then another oral therapy or a higher level therapy such as an inhaled prostanoid or an infusion prostanoid, or now some oral prostanoids which have been more recently approved, may be added. That's referred to as sequential therapy. So it appears that more medications earlier in the course after the diagnosis is where the practice is headed in terms of current evidence that's been forthcoming over the last year or so, but more needs to be done for confirmation of that. I would estimate that the majority of pulmonary arterial hypertension experts are inclined to use as aggressive a therapy as indicated as early as possible to get the right heart size and function to a more normal state, because clearly that has the best chance of keeping people out of the hospital, keeping them off of transplant lists, and improving survival. So sequential therapy is sort of where we've been, and that's how it's generally evaluated, although using more drugs earlier in the course may be where the practice and state of the art for treatment intervention moves really over the next year or two, quite frankly, as we look at changes that have already occurred in current guidelines. As more therapies have become available, then the decision-making on upfront therapy or sequential therapy becomes a bit more complex. We now have oral medications with 3 different targets for intervening on the pulmonary arterial narrowing. We have a pathway that involves prostacyclin, so oral prostanoids. We have a pathway involving endothelin, so blocking endothelin with endothelin receptor antagonists, and a pathway involving nitric oxide, which has 2 different types of oral medications. So it would make sense from a scientific perspective to hit each of those targets aggressively as quickly as possible to improve the patient's symptom state and to lessen these harder endpoints. How quickly all of these medications need to be added really needs some additional investigation to enhance the guideline recommendations so that practicing clinicians who are prescribing these therapies have a bit more in the way of at least consensus-based recommendation, if not scientifically proven recommendation, on how to use the various drugs that are now FDA approved for this disease. If you're comparing infusion prostanoid therapy to the inhaled preparations, there are several important differences. With the infusion therapies, you have a constant dose that's being provided systemically to which the pulmonary arterial circulation and the right heart is exposed. You have a high degree of confidence that the dose that you're providing, either intravenously or subcutaneously, is absorbed and is meeting your target blood level for action on the disease state. Secondly, it's zero-order kinetics, so there are no peaks and troughs of the medication. The exposure to the medication doesn't vary whether you're awake and taking the medication as it would with an inhaled preparation. It's 24 hours, same dose, same exposure. With the inhaled preparations, of course, it requires a delivery system, and the medication is prepared and put in a delivery system, typically a proprietary delivery system or nebulizer in some cases. The medication, of course, is then delivered to the respiratory tract, some of which has to be hitting the oral pharynx or the upper GI tract or the larger airways and perhaps not getting into the lower airways where the drug is active. It's not clear how much might be absorbed systemically versus active locally in the pulmonary arterial circulation. There are peaks and troughs, of course, so you have a high peak level right after you've administered it, and then the drug is metabolized, and then, of course, there's no coverage during nighttime because you aren't delivering the drug while the patient's asleep, so there's a gap where the trough level of the medication is persistent beyond what you would anticipate would be the best for the patient in terms of therapeutic exposure. And then, of course, you have issues of potentially irritating the respiratory tract, causing cough and wheezing that could also affect how much of the drug you're delivering into the system.